Maybe this title is not very correct because it might sound a little bit paternalistic. Listening to what we heard today, already this afternoon and in the morning, what is already achieved in this field. And this is a field where both working or all different parties are working together. And I can tell you that's a clear, open secret. The work I'm doing in HIV was fertilized already by the hepatitis elimination strategy. So it's a vice versa. It's not a one-way street. Nevertheless, to give you some background and maybe some ideas of the lessons that could be learned and walking together into the future, we need to appreciate the history. And let's look where we are coming from. In the early 90s, this man received a diagnosis of HIV/AIDS, and this was a death sentence. He tried to organize himself, nicely depicted in this movie, Dallas Buyers Club. He crossed the border to Mexico, which would not so be easy today, and he got to get the drugs there, antiretroviral therapy. Unfortunately, these drugs were not potent enough to save his life. But definitely, this was a template. This activist was showing where we could go. And this was used then later on, mentioned today, what Aru did, and especially what the Australians did. This is the template coming from Australia at that time. So this is a lesson learned from HIV, bringing back into the field of hepatitis. We know that until 1996 we had no other choice than palliative care, but then we had antiretroviral therapy, potent antiretroviral therapy, and we had a clear decline also in Switzerland in terms of death in regard of HIV/AIDS. The most affected population was the population of drug addicts. And if you would have been taking a walk through Zurich 25 years ago, mainly through the Needle Park, this would have been the picture you would have seen. And this was a terrible situation. People living in miserable situations, sharing needles, dirty needles, infected needles. That's where we are coming from. And the situation came only under control when the four-pillar policy was established. And I think this was something where we could say Switzerland had somehow a pioneer role and also appreciated by the WHO. So this consists of 4 pillars of prevention, treatment, and harm reduction, and mainly opioid substitution programs, not in the whole of the world represented today, sadly not. And repression was also part of it, control, but in a moderate way. This was only possible because all different stakeholders came together, politicians, doctors, nurses, researchers, lawyers, everybody was on board to create a situation to face this challenge. Where did we arrive? Where are we now? So we learned, prevention works, but also treatment works. HIV became a treatable disease, and our patients became mothers, fathers, and even grandparents to HIV-negative, healthy children. So this is a firm statement, and I couldn't say it better than David Cooper did, saying the story of HIV is a modern medical miracle. From despair and tragedy, we have moved into an era of chronic treatable illness in just 30 years. Again, this is a protagonist from Australia, and I'm really curious about the next talk we're going to listen to. That's David Cooper, and unfortunately he died this year. The next most important brick in the wall was the Swiss statement, saying that well-treated patients are no longer can no longer transmit their virus. It's a clear statement saying that condomless sex is possible, A, and that's something we learned from our patients. So that's another learning. That's not the secret, but we need to listen to our patients because the initiative came from there. And we were then, after that, thinking of how could we integrate this in our daily practice. This was a firm statement against stigma, a firm statement against discrimination, very, very important, which laid ground to normalization for people living with HIV. So it was also the basis for a principle, for a concept. And this concept was later on, and you saw this this afternoon in what Dominic Brown presented, this was basically also the concept for the HC3 trial. If somebody is has no longer the virus, or has a virus which is under control, he cannot transmit this virus. This is the approach of treatment as prevention. So this is the baseline here, you can see. So we have a healthy population on the background here. This was endorsed and proclaimed, and also from the UNAIDS, an ambitious target to eliminate or to end the epidemic by 2030, saying that, taking this example of 1990, or the program of 1990, 90% have to be diagnosed, 90% of HIV-infected people on treatment, and 90% virologically suppressed. Switzerland has endorsed and approved this 2016. And again, here I can see some shares with hepatitis elimination ideas. So I think this is really co-fertilized. Where are we now in Switzerland? So this is the graph we receive every year from the Federal Office of Public Health. 2016, we have had 524 HIV-infected individuals, mostly men having sex with men. Where are we in terms of the 1990 in Switzerland? The last two 90s, so being on treatment and virologically suppressed, this is fine. We are even doing better than what WHO is giving us as a goal. But the problem lies in the first 90s, so in the ones we need to diagnose. And we have an estimated number of 3,000 HIV-infected individuals in Switzerland not knowing about their status. And I think that's really a concern, and it's also a concern, it's not just about making them aware of their disease and bring them into the health system in order to that they can benefit of the treatment. We also want, of course, to prevent the HIV infection. And here we have some interesting tools already mentioned this afternoon. So one is definitely the new one on the block, or the newer, is PrEP, pre-exposure prophylaxis. And I think this is something we really need to think how we can come together. Swiss Prepared was mentioned. This is the program we are going to start in basically all the regions in Switzerland. So there are 7 HIV cohort centers, which are the cantonal and university hospitals, and 5 checkpoints. Sometimes they are both together, like Bern has a checkpoint together with the SHCS center. And we have also GPs, and we have healthcare centers. This is something which hopefully depends a little bit on also ethical committee and different aspects. Hopefully we can launch this first project 1st of December for the World HIV/AIDS Day. That would be fantastic. And here again we have a close collaboration with different partners, namely also with the Swiss AIDS Federation. That's really instrumental to us, because there are many aspects like campaign and so on. And what is needed if we look at HIV/AIDS to really come down to 0 new infection 2030? So there are basically 3 things. PrEP, definitely could help. And it's not only PrEP alone. It's the possibility, the opportunity to talk about all the different risks and to get aware of all which lies around. So like chemsex or being in the virtual room. That's something we learned really definitely from the HC3 trial. We had very good insights from this side. Then, of course, treatment as prevention is so important. You heard about the Swiss HIV cohort several times this afternoon. To keep the level of people on ART being maximally suppressed virologically. That's very, very important. And of course, we don't want to forget all the campaign about the general population, which is important as well, but we need to be more targeted in the future. I think that's definitely clear. So where could we go to? Is it just a dream? Again, hot off the press here from Melbourne, there is this data published in Lancet, I think beginning of September, and here you can see the PrEP program, which was started in 2016, and the red dots, there is the new diagnoses are depicted. They're falling down to a considerable lower number in 2017. And the bars, you can see the bars are the numbers of tests that were provided. So this has also to go hand in hand. Not just providing tests, doing the right test in the right population. That's very, very important because there are also programs we know from former Soviet Union where they just randomly test many, many people, and that's not very useful. And of course, you lower the prevalence artificially. So that's not the aim, definitely not. Again, we have to be a little bit cautious about these new data because at the same time, TASP treatment as prevention has maybe really come into play, which is an important factor as well. But let's say it's encouraging. And also, if we look at different places, UK has same figures, and also lately published in the CID, we have certain figures up to 50% reduction from San Francisco. Okay, as a summary, we started with AIDS. We had the 4 pillars prevention program I was showing. It went to a chronic disease once ART was available in 1996. Swiss HIV cohort was established in 1988. This was an important thing. It was important because it's a tool for observation, for surveillance, but at the same time, it's also intervention. And the Swiss statement, treatment as prevention, came then into play. And nowadays, we have new possibilities for prevention, which definitely PrEP plays a role. And I would call it's a bundle. So different measures should come on board. So why was it a success story, if we call it like this? And I think there is some good reason. Here you can see the Elbphilharmonie. And like this, I mean, it's a beautiful building. It's perfect, perfect acoustic. But we need somebody who is playing in it. It's the orchestra. We need an orchestrated approach. That's tremendously important. And in the last few minutes, I will walk you through this circle I drawed about the joint forces. So first of all, and this is in the center, is awareness. It's so important. I think one of the biggest differences between HIV/AIDS and the field of viral hepatitis is awareness. That's definitely clear. And also attitude. It's not enough to be aware of something. Because maybe these doctors, they have done in the study Andrea Bregenzer was showing, they have at least done a basic antibody test, but then they didn't go further. So maybe it's also an attitude, and then maybe that's something you were pointing out, and I'm sure you were pointing out this, Claude, saying that it needs a system readiness, it needs a healthcare providers' readiness, so the attitude to, yes, we do something about it. Also, if it's more difficult. We have to go to the extra mile sometimes for our difficult situations. I don't say difficult patients, for our difficult situations. And then, of course, there must be some readiness on the patient's side. We need political will. We need resources, that's clear. We need an agenda, we need the know-how, and I think that's nicely shown in the Swiss HIV cohort study, for example. A little small country was really able to give some very, very crucial data which is useful for the whole community of researchers, programists, the stakeholders in the whole of the world. Then, of course, we have our partners on the side of the industry. We need this integrated in the national programs. And there's one little tiny sentence right now in the national program for preventing sexual diseases about hepatitis, about viral hepatitis. And I think in the next program, which is going to start in 2021, this should be endorsed. This should be endorsed. That's important. Then, of course, infrastructure is important, but infrastructure basically is here. And it's how to make best use of this infrastructure. And it needs something in addition. It needs courage, vision, and passion. Because the Swiss statement would never have been possible if we just would have waited until we get this data to be really sure that we can go for a firm recommendation. It was courageous from this point of view to go into such a statement. And I remember this was launched a Wednesday, and on the Thursday there came emails from CDC saying that you Swiss people, you're completely crazy. You're completely crazy. Come out something with that. This was really something important, and I think that's something which we shouldn't forget, beside all the infrastructure and different aspects. So here I don't want to go into further discussion, because I think this is going to be part of the discussion right afterwards, but it's just food for thought where we are. And I will end up with this one, which is saying, and I'm coming to my start, it's not definitely giving lessons learned to the community of viral hepatitis. It's thinking of how we can use the already existing pathways to come together and make best use to twin these both topics. And if we are able to do so, we are going to be champions, I'm quite sure. For certain topics, we're a little bit late. Others are faster than us, but we can learn from them. But if we really can merge both, it's a good aspect. And it's good also because it's not just twice spending the same amount of money. It's maybe half-half, but we use the same streets and backyard streets as well. So this would be my ending, and I thank you very much for your attention.